I strongly believe that modern glaucoma treatment involves laser treatment. For patients with ocular hypertension or early glaucoma, SLT is the main treatment nowadays. Moving to the other side, it's patients with more advanced disease that require a more significant pressure reduction. Then CPC is a very good alternative. So the system itself is very flexible and it's a significant advantage. We do not use the same protocol for every single patient. You can deliver more powerful treatment for a patient with higher pressures, multiple medications. You can use a continuous laser. And for a patient that requires lower pressure reduction, patient using not so many medications, you can use the SP, subthreshold mode. You can treat patients with pressures around 18 to 20, 3 medications, 20/20 visual acuity. Or imagine you have an 83-year-old patient, woman, pseudophakic, pressures around 19, with like medication issues. And I just do laser. You can see the patient like 3 days after the laser treatment. Then the patient come back to the office like 2 weeks later. It's totally different postoperative management than I used to have for the same patient when indicating trap. So every surgeon knows that, surgery in these small eyes may be tricky. We may have significant complications such as malignant glaucoma and very hard to manage complications. So no one wants to perform filtering surgery in these eyes. Our research project involved two-step approach. So we begin with CPC, pressures are high, we bring pressures down, we improve ocular surface, then we perform cataract surgery. The laser system is on, so we are going to look for our settings. This is the double arc protocol using slow coagulation technique. For this specific protocol, we use 1,400 milliwatts per second. This is the continuous protocol. You're using the probe for continuous laser application. Here, beginning the treatment. Just keep pushing for 4 seconds. We avoid 3 and 9 o'clock hours due to the ciliary nerves and vessels. It's one application at a time. 4 seconds. Then we move 1.5 millimeters back and do another application. It should be perpendicular to the eye wall, to the sclera. You should apply force here over the sclera to avoid anything between the sclera and the laser tip. I believe that the most convincing arguments to integrate CPC in your practice would definitely be related to a good combination between efficacy and safety, moderate to advanced glaucoma, no central visual field defects, and all these patients were being treated equally to patients with pressures around 40, very advanced glaucoma, central visual field loss. They all were receiving or being treated with traps. If you have access to a laser, to CPC, you'll definitely start to treating your patients with pressures around 20, 19, pseudophakic patients without central visual field loss. You have some cases that are like no-brainer for patients with multiple surgeries, for patients requiring a first tube shunt, and again, for selected cases, as a first alternative, even before a conventional filtering trap. So regarding my experience with LIGHTLas A10 system so far, it's been very, very positive. It provides me, reliable, consistent outcomes, at least in my hands so far. I've performed over 300 cases. Many of our studies, we use the LIGHTLas laser. So very predictable, very safe outcome. It's a more refined, predictable, and dynamic laser system, which again is crucial for, customizing your treatment for every patient.